This video explores the central hypothesis of the paper: muscle PTSD, predictive processing, and reinforcement learning, reimagining and treating non-specific musculoskeletal disorders as mind-body conditions, authored by Robert K. Weisfeld. It will outline the muscle movement motor PTSD model, which provides a hypothetical rendition of the mechanisms behind the establishment and remediation of muscle weakness or inhibition.
Physical medicine practitioners know that patients who show up in pain, from office workers to athletes, invariably have weak muscles around their area of complaint. Research and clinical experience shows that this weakness, often called arthrogenic muscle inhibition, is resistant to standard therapies and exercise. Even after functional recovery, patients are often released from care with chronically inhibited muscles. The mechanisms underlying muscle inhibition remain murky. Nonetheless, 6 decades of clinical reports from alternative practices show that inhibition can be reversed. Although the efficacy of these practices has not been comprehensively studied, experience with these methods made me curious. Is there a mechanism that might explain both the presence of chronic muscle weakness and its reversal? The muscle motor movement PTSD model, the mPTSD model, proposes a novel framework for understanding inhibition. It suggests a 2-stage learning process grounded in predictive processing and reinforcement learning. First, a precipitating event, pain, injury, or other trauma, occurs concurrently with the use of specific muscles. Signals indicating error are transmitted to the cerebellum, which, through classical or operant conditioning, updates its internal forward models. Thereafter, cerebellum predicts pain or trauma when these muscles are used, leading to their avoidance. This may be an example of passive avoidance learning. In the second compensatory stage, the cerebellum and motor cortex form new muscle synergies via operant conditioning, avoiding reliance on trauma-associated muscles. Even with apparent recovery, these compensatory synergies are less stable and inefficient. This increases risks of further pain or injury and diminishes performance. Experimental evidence supports the hypothesis that testing a weak muscle reactivates its trauma association memory. Memory reconsolidation theory suggests that this destabilizes the memory. Physiology-altering treatments may disrupt reconsolidation. By systematically testing and offering treatment for each muscle in and around a dysfunctional area, muscle trauma association memories are functionally eliminated. This may allow pre-trauma function to be restored, potentially resolving acute or chronic musculoskeletal symptoms.